So I literally have been slam dunked with a lot of work, and we've been having some power outages, so it's been very difficult to actually work and edit these videos. The least you could do is at least show some support and subscribe to the channel. Hit the bell notification icon so you never miss on such amazing content every time I post. I really hope this is not going to be a long lecture, but I have a feeling it's going to be very long. I'll try and make it as short as possible. Let's talk about myocardial infarction, with a focus largely looking at the STEMIs, the ST segment elevation myocardial infarction. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at the STEMIs, the ST segment elevation myocardial infarction. If you haven't yet subscribed to the channel, what are you waiting for? Hit the subscribe button, hit the bell notification icon to receive notifications of such amazing content every time I post. We're on the road to 26,000 subscribers. We have passed our target for this end of the year. Well before the year actually has ended, we have passed 25,000 subscribers. So I'm going to give you first a little bit of a background in terms of ischemic heart disease. Then we'll talk about atherosclerosis. Then we'll talk about STEMIs and how we're going to be managing these STEMIs. Remember that in as much as the heart does carry blood in it and it's going to consist of oxygen inside it, it's not enough to travel across the entire myocardial thickness to offer the essential supply of oxygen for the purpose of metabolism, because the myocardium is quite thick. So because of this, there is a system that was developed, or there is a system in the heart that's known as the coronary system, which pretty much supplies the heart muscle with the right nutrients and the right oxygen for it to function very well. If there is a problem or a blockage, or maybe there is something wrong with this coronary circulation, it will invariably lead to these tissues respiring anaerobically of the heart muscle, and eventually the heart muscle is going to die. So the presence of features of cardiac ischemia is what we refer to as ischemic heart disease, or coronary heart disease, or you can call it coronary artery disease. So there's largely going to be an imbalance between the oxygen demand, which is going to be increased. So this would be in the background of someone who's doing some sort of exercise. Sometimes these things do even happen at rest. And in addition to this demand cannot be met by a supply, because remember that the coronary vasculature has been blocked. So this invariably will result in myocardial hypoxemia. This is going to result in cardiac death, which is pretty much your ischemic heart disease. So the most commonest cause of the ischemic heart disease is going to be atherosclerosis. Remember, this is going to be this lipid-rich deposition of this or formation of these plaques inside the walls of the coronary vasculature, and this is going to be the main cause of ischemic heart disease. So in terms of presentation, it could largely present as an angina. Remember, this means chest pain. Could be a stable angina, which often comes on with exertion and stops without exercise. And you have another type of angina that's known as Prince-Metal or vasospastic angina. Then you have the acute coronary syndrome, which is what I'm going to be focusing much on in this lecture. Pretty much going to be focusing on the ST segment elevation myocardial infarction. We won't really talk about unstable angina, and we'll talk a little bit about the non-ST segment elevation myocardial infarction. So what are some of the risk factors that are going to be associated with ischemic heart disease? These can largely be divided into two main groups. So there are going to be things that you can change, which are referred to as modifiable risk factors, and things that you can't change, which are known as non-modifiable risk factors. So the things that you can change, or the things that you can intervene as a person, as a general practitioner, as a physician that's seeing this patient. You can address the hypertension. Remember that hypertension is a risk factor for atherosclerosis. Atherosclerosis is a risk factor for hypertension. Hypertension in itself is going to be causing some sort of damage to the blood vessels. This is going to lead to this constant chronic inflammation, which essentially, even when you look at the pathophysiology of atherosclerosis, is going to lead to atherosclerosis. It is an increased risk in both women and men to develop coronary artery disease. Dyslipidemias is also another big thing. Remember, they are what we refer to as the good lipids, which are known as HDL, the high-density lipoproteins, because they have higher contents of the apolipoproteins and very little fat content, quote unquote. But the low-density lipoproteins are the bad lipids. So in people that have increase in LDLs, the bad lipids, they have a lot of total cholesterol, and even the ratio of cholesterol to HDL is high, and they have reduction in the good lipids, which are the HDLs. These ones are at risk of coronary artery disease. Diabetes also has been associated with significant increase in risk of coronary artery disease. Remember, it's also may be associated with some form of dyslipidemia. You have other risk factors like smoking. Remember that 60% of people that smoke cigarettes are likely to develop coronary artery disease compared to the non-smokers. You also have other things like excessive alcohol intake, obesity, which is an important thing because I think they should be due to the effects of estrogen. Remember that the fat cells have the ability to convert the androgens into a form of estrogen that's known as estrone, which has been implicated in cardiovascular changes in the body. Then those that are taking oral contraceptive pills, especially the combined oral contraceptive pills, again, the problem is estrogen, and also those individuals with gout. Then you have non-modifiable risk factors, things that you can't really change. You can't change your age, no matter how young you say you are or how old you say you are. Even if you say you're forever young, you can't change your age. So this does increase. An increase in age increases the risk of you having a coronary artery disease, 1.5 in 1,000 individuals at the age of 50. That's quite significant. Then gender, of course, those that are very young, the prevalence is actually much more in men than women because the hormones are sort of protective in a young woman's body. But postmenopausal, the difference actually becomes quite similar. Then in terms of ethnicity, it's common in those that are of South Asian ethnicity, those that have medical history of atheroma or any phenomena associated with this. It could be a patient that had a myocardial infarction in the past, they're at risk of having another one. It could be someone that's had a stroke, someone that's had a pulmonary thromboembolism. And then it could also be in the background of some genetics that are associated, family history. If you have a myocardial infarction, especially in a first-degree relative, in a male that is less than 55 years, in a female less than 65 years, you should suspect that there may be some genetics that may be associated. I'm not going to go into details of that. So when you talk about acute coronary syndrome, remember that here you're going to have a patient that's have this atheromatous plaque, and this atheromatous plaque has progressed and it has undergone what is known as rupture. Once it undergoes rupture, it becomes thrombogenic. It means it's going to easily activate the platelets. It's going to easily cause platelets to be aggregated and to accumulate, and may sometimes even completely obstruct the lumen, causing this coronary artery obstruction because of the thrombus that has formed and the vessel that has been occluded. Depending on how much of the blood vessel has been occluded, you may actually get symptoms or not. Some symptoms may come in even at rest. For example, if the platelet propagates and grows and entirely blocks the entire lumen, it's going to lead to symptoms even at rest. And then sometimes if the blockage is less than 70% of the entire lumen, then this patient may get symptoms when they start exercising. Then sometimes the change in the size of this thrombus may progress over time and they get symptoms even as with less progressive work. So generally you have three main types of the acute coronary syndromes. You have the ST segment elevation myocardial infarction, which I will talk about in this lecture. And you have the STEMIs, which is the non-ST segment elevation myocardial infarction, and you have the unstable angina, which I won't really talk about in this lecture. So when we talk about ST segment elevation myocardial infarction, these are changes that we're seeing on the ECG. You're going to see ST segment elevation in contiguous leads. I did a very good ECG playlist. If you did not check that out, please check that out. It's on the playlist. I'll leave it tagged in the description. I'll also leave it tagged at the end. So you may have an increase in the troponins, which are the cardiac enzymes. You also get an increase in the ST segment. You get an elevation of the ST segment. Remember that in practice, if you see someone coming in with symptoms and you do an ECG quickly and you realize that there's ST segment elevation on the ECG, that alone is enough for you to treat your patients. You don't want to wait for the troponins to rise because they may take a bit of some time. So you want to treat your patients just based on your ECG and your symptoms. Do not wait for the labs. Then for the non-ST segment elevation, you get an increase in the troponins and you have some ischemic symptoms, or they may sometimes even have some ECG changes. In unstable angina, they're going to have this prolonged we are going to have this severe chest pains, and then this is also going to be present at rest. They may also have some ECG changes, which I will look at, but we talked about these ECG changes a lot in details in the ECG playlist, so please check that out. Now, before diving into details of the STEMIs and how we're going to be managing them, you need to have a good background on what atherosclerosis is. Remember that this is the blood vessels are going to be divided into predominantly 3 layers. You have a tunica intima, or which is known as the endothelium. You have the tunica media, which is pretty much the muscle layer, which has the smooth muscles. And you have the tunica adventitia, which is the outer layer, like the serosa of the blood vessels. So in terms of atherosclerosis, this is a problem that is resulting in an intimal lesion that's going to be created, which is known as an atheroma. Some books will refer to it as an atheromatous. Other books will refer to it as an atherosclerotic plaque. Now, these things, when you look at them under the microscope, they're going to be this soft yellow. They're going to have a lot of macrophages that have a lot of lipids in them. We call them as foam cells. They're going to have a lot of cholesterol. They're going to have a lot of cholesterol esters, and they'll have some necrotic debris, which is going to be surrounded by a fibromuscular capsule or a fibromuscular cap. And these thrombi can actually be formed in many different types of vessels, but commonly we tend to see them in the coronary vessels. So inside the coronary vessels, they can actually cause platelets to also aggregate on top when they undergo roughenings, and this can actually lead to mechanical obstruction of the vascular lumen, and it can sometimes even result in rupture, because remember that the atheromatous plaque is also going to be weakening the tunica media, so it means it's very easy for aneurysms to actually form. It's very easy for these aneurysms to rupture, and this is quite catastrophic for the patient. So it's going to begin as a process that's starting off with the intima, but then with changes, it's also going to be affecting the media. So like I already said, here if we focus on this diagram on the right, we have the tunica intima, tunica media, and tunica adventitia. And then, of course, you're going to have these lipids that are accumulating in the wall. You're going to have macrophages inside there that are engulfing and trying to metabolize these lipids. Then they get activated. They start producing these cytokines, which stimulate even other cells to begin to divide. And then you're going to form this atheromatous plaque. It may undergo disruption where platelets now are going to be activated, and these platelets are going to aggregate, and this may sometimes cause the obstruction. So if it completely closes the obstruction, then of course this person is going to have a transmural type of infarction, or they may even have a sudden death. They may not actually even survive. Then if it blocks part of the lumen, that's when they can present with either an unstable angina, they can present with an acute subendocardial myocardial infarction, they can also even present with a sudden death. So sometimes this may heal, and then they'll have this severe fixed coronary obstruction. So they'll have this chronic type of ischemic heart disease. Now, what exactly causes this atheromatous plaque to form in the first place? So there are many different theories that are there. 2 quite popular theories is that people think that this is because there is proliferation of these cells of the blood vessel because there is some sort of injury that is there. One theory actually focuses much on that. There is proliferation of these cells of the blood vessels because of chronic injury that we see. Another theory states that you have this formation and this organization of this thrombi. So these 2 different theories that are going to be explaining how the atheromatous plaque actually comes into existence. But there is another theory which is known as the contemporary theory, which combines both of these 2 principles. So there is what is we now refer to as the response to injury hypothesis. So there's going to be some sort of inflammation that is happening, and the blood vessel walls are going to be responding to this sort of endothelial damage. And this later or eventually is going to lead to interaction of many white blood cells, like the macrophages, like the T lymphocytes, and even cells of the walls of the arteries. So you also even have these modified lipoproteins that are going to be depositing in these areas, the cholesterols and the cholesterol esters. So what's happening now in the pathogenesis of this condition? You have some sort of injury that is going to be there. So this injury could be made worse if a patient has a hyperlipidemia or dyslipidemia, if they have hypertension, if they smoke. Homocysteine is another important example, because remember that homocystinemia, hyperhomocystinemia, can be as a result in patients that have folic acid deficiency. Remember that folic acid is going to be pretty much circulating in the body as a compound that's known as tetrahydrofolate, which has a methyl group. This methyl group is supposed to be passed on to vitamin B12, and then eventually the B12 is supposed to pass on this methyl group to homocysteine, converting it into methionine, which is needed for DNA synthesis. Now, if you don't have the vitamin B12 or you don't have the folic acid, sometimes you may have accumulation of the homocysteine, which can actually cause damage to the endothelium. You may have some other hemodynamic factors, toxins, viruses, and even immune reactions that are causing some sort of chronic endothelial injury. So remember that once these cells are injured, they're going to become dysfunctional. The permeability of these endothelium is going to increase. White blood cells begin to stick to the endothelium because of the response to this injury. And of course, platelets are going to be activated and they begin to settle in that particular area. In addition to this, remember that the macrophages actually have an LDL receptor, and they actually can internalize these low-density lipoproteins and attempt to oxidize them. And then they're going to eventually have accumulation of a lot of these inside their cytoplasm, so they now begin to be called a special type of cell, which are known as foam cells. So there's going to be some accumulation of these lipoproteins because the macrophages have been activated. They have also recruited other cells, and in essence, there's going to be now, they're going to try and engulf these lipids, and these lipids are going to accumulate in them. They also start producing various cytokines, certain inflammatory cytokines, and these are going to be now stimulating smooth muscles to begin to proliferate from the tunica media, even from other circulating precursor cells. And then eventually there's going to be this smooth muscle proliferation, the extracellular matrix that's going to be produced, and you're going to form this nice thing that is enclosed, which is known as an atheromatous plaque. So it's predominantly going to have this fibromuscular cap, which is going to consist of smooth muscle cells. It's going to have macrophages, the foam cells, the lymphocytes, the collagen, elastin, proteoglycans, and some new blood vessels that are even forming. Then it may have a necrotic center that has cell debris. It has cholesterol crystals. It may have the foam cells. It may even have deposits of calcium. Then here you have the tunica media. So this is what is the basic structure of an atheromatous plaque. So generally, once this atheromatous plaque actually forms, some things can actually happen to it. So sometimes your plaque is going to keep growing until it reaches a critical point where symptoms are going to come about. That's 70%. If the obstruction now is greater than 70%, that's critical stenosis. Sometimes it may progress. The plaque may undergo rupture or erosion. It may sometimes undergo plaque hemorrhage, and you're going to have this thrombi this platelets that are aggregated and accumulating there. Sometimes the thrombus can occlude the entire blood vessel. In some cases, because the tunica media has been weakened, it may actually lead to aneurysms that could actually rupture. Usually, these symptoms are going to come in when someone is in the middle age or towards the elderly age. But we have noticed that some of these changes actually are seen much, much earlier, even before, as early as the patient is in the teen years, because some of these fats can actually accumulate in the walls of the blood vessels and cause what we call fat streaks. And these fat streaks can actually be seen much, much earlier before you actually even progress and have these symptoms that are coming about in this particular patient. Now, what are some of the complications of having an atheromatous plaque or atherosclerosis? Like I said, it can occlude a blood vessel, resulting in those characteristic symptoms depending on which organ is affected. The plaque can undergo disruption. It can cause platelets to be activated for them to aggregate. And depending on where you are, if it's in the coronary artery, it is going to result in a myocardial infarction. If it's in the blood vessels of the cerebral, or maybe like, for example, the middle cerebral artery, to result in a stroke. Sometimes these thrombi can break off and form emboli and go block even other blood vessels in other areas, like, for example, in the lungs, forming a pulmonary embolism. You may sometimes form these aneurysms that may rupture. This dilatation or circular outpouching of the vessels, they may sometimes rupture. Sometimes you may have it affecting the middle-sized vessels and causing them to harden. This stenosis, if it's in the popliteal artery, you may have peripheral vascular disease. You may have angina if it's in the coronary arteries. You may have ischemic bowel disease if it's in the mesenteric arteries. And remember, with peripheral vascular disease, this person is going to have what is known as intermittent claudication. Every time they attempt to walk, they're using more energy, they require more oxygen, but this cannot be afforded because there is an obstruction of that blood vessel. So it means that those muscles respire anaerobically, they accumulate lactic acid. This causes pain in those muscles, or cramping or aching in those muscles. When they stop the exercise or the exertion, it goes away. We call this as intermittent claudication. They may sometimes have these cool extremities, they may have diminished pulses, they may have shiny and hairy skin. The patients may sometimes even have severe peripheral vascular disease where they have this pain at wrist. Sometimes they may have ischemic ulcerations, which are a common cause of morbidity. And remember, all this is because of the atherosclerosis that's going to be affecting the lower extremities. Now, how is a patient with a STEMI going to present? What are the clinical features that we should look out for? The key thing that you may see is chest pain in most of the people. And remember, in evaluating chest pain, we use Socrates, the site, onset, character, radiation, associated symptoms and signs, the timing, the exacerbating factors, and the severity. So the site is usually central, so these people are going to present with central chest pain. Remember, central chest pain sometimes could be a myocardial infarction, it could be a PUD, peptic ulcer disease, it could be pancreatitis, for example. The onset is rather sudden, but sometimes it can be gradual. You're going to feel this tight feeling in the chest, this crushing feeling. It's not a sharp type of pain. For example, if you have an aortic dissection, it's going to be rather central, but it will be sharp. But that's not the case here. It's not a sharp type of pain. It's a crushing, tight type of pain. It radiates to the left arm, then the neck, the jaw, sometimes the back, sometimes the right arm, sometimes even the epigastrium. They may have other associated symptoms like sweating. They may have clamminess, shortness of breath, dizziness, fainting. They may have anger, anemia, which is pretty much this impending sense of doom. And remember that the duration of all this is past 15 minutes. All this has been happening for the past 15 minutes. It could be a patient that has angina and they have already taken the GTN spray and it hasn't worked. They may have some exacerbating factors like exertion, emotions, eating. And remember that if they may also have relieving factors, if these are present, then ACS is less likely. So if they took the GTN spray, the glycerol trinitrate, and the symptoms disappear, it's more likely that they had an angina as opposed to an acute coronary syndrome. Of course, severity is high, but sometimes can be atypically low, especially in patients that are elderly, patients that are DM patients. They may have what is known as a silent MI, where they don't have those characteristic symptoms of an MI. So you must be vigilant. So they may sometimes have little to no chest pain. They may just have shortness of breath. They may have sweating, nausea, and vomiting. That's about it. Then there may be some signs like increase in the heart rate and the blood pressure. Sometimes it may be decreased. They may be pale. They may have an S3 or an S4 heart sound, very common, especially in the STEMIs. Now, how do we make a diagnosis? So generally, two important things you want to do for your patient. Well, the single most important thing is get them an ECG. So when they come in and you're suspecting that this patient has a myocardial infarction, you want to do an ECG because you want to pick up your STEMIs from the ECG. I think I did a very good job at teaching you how to pick the STEMIs in my ECG playlist, so I will leave it tagged at the end of this video. So if you do your ECG and it's negative, there's no features of ST segment elevation myocardial infarction, and you are still having a high index of suspicion that this could be a STEMI because the pain is continued and the suspicion is still high, you can still repeat the ECG after 20 minutes. I'll go ahead and remind you a bit in the next few slides about the ECG things that you should look for in terms of an acute myocardial infarction for those that are too lazy to watch the playlist. So remember that ECG is about 85% diagnostic. You may have either a transmural MI that's going to show you this ST segment elevation and contiguous leads. And there are certain changes that are time dependent on the ECG. I will cover that very shortly. Or it could be a subendocardial infarction where now the ECG findings are less certain and there may sometimes even be ST segment depression. Again, I will explain very shortly what I mean by subendocardial infarction and what I mean by transmural infarction. So don't worry if you don't understand about them right now. Then you also want to get some cardiac enzymes. The troponin T and troponin I are quite specific, so you test them on admission and after 36 hours. Remember that the troponins usually peak at 12 to 24 hours and they decline over 10 days. And remember that troponin I is the most sensitive and specific marker for myocardial infarction, and the levels rise within 24 hours. You can also do your creatinine phosphokinase enzymes, and these tend to elevate after 6 hours, and after infarction, the AST elevates 12 hours after infarction. LDH is going to start to elevate 24 hours after infarction. So these ones elevate quite a longer time. And remember, there are some things that can cause your troponins to elevate. Remember the acronym or the mnemonic heart dies. So heart failure, pulmonary embolism, atrial fibrillation, renal failure, because there is reduced clearance of those enzymes, thrombosis, dissection of the aorta, inflammation or myocarditis or pericarditis, exercise, very strenuous exercise, and even sepsis. You want to get a chest x-ray to rule out any other cause and to check for any features of heart failure. Get a full blood count because someone with a low HB, it may actually exacerbate strain on the heart. And you also want to get a baseline HB and a baseline platelet count before you actually start them on anticoagulation. Guys, remember, you're going to either start them on some sort of thrombolytic therapy, and remember, if they are thrombocytopenic, this may be a contraindication to thrombolytic therapy. Then check your urea and electrolytes for baseline before you give them some anticoagulants and ACE inhibitors. Also screen for renal disease for those that have hypertension. Get your glucose, because someone with a very low glucose, again, you don't want to give them your DPAs. You want to, again, address that before. Then check a lipid profile on admission, and remember that cholesterol is going to dip 24 hours post the MI. So I now want to go into a bit more detail talking about the ECG before we come to talk about the management of the condition. Remember that the ST segment elevation, generally you want to look for the coronary distribution, which vessels are affected. You want to identify the typical pattern, and you want to actually tell how old this infarct is, whether it's a new thing, whether it's a hyperacute thing, whether it's an acute thing, whether it's an evolving MI, or whether it's a fully evolved MI. So remember that sometimes you may see it affecting the posterior aspect of the myocardium, which you can't really, there is no lead typically on the 12-lead ECG that represents the posterior myocardium. So you'll get mirror changes on those same leads. So what do I mean by mirror changes on those leads? For example, you're going to get ST segment changes in lead V1, V2, V3. So whenever you see there's some sort of ST segment horizontal depression in these leads, maybe they are tall, broad R waves that are greater than 30 milliseconds. Maybe they are upright T waves. Maybe there's a dominant R wave in V2. Maybe you should suspect that there's a posterior MI. That's the only thing that I want you to remain vigilant about. And remember also that right ventricular involvement should be suspected if there is an inferior MI. Now, remember that the heart muscle has these coronary vessels that are supplying each of these heart muscles. So if this vessel is partially obstructed, remember that the supply is going to be from the outside going to the inside there. So if this blood vessel is partially obstructed and this heart muscle has increased its demand, then the demand cannot be met with the supply. It means that the heart muscle which is furthest from this blood vessel will begin to die first. So if in the partial obstruction or in the early phases of ischemia, in the early phases of this obstruction, early phases of infarction, the layers which are going to die are the ones that are just underneath the endocardium. We refer to those as the subendocardial infarction. This usually we see this with the partial occlusion or the transient. So here you may actually see some ST segment depression. You may see some T wave inversion. Now, if the entire lumen is blocked, it means that the entire myocardium is not receiving oxygen. The entire myocardium will begin to die. We call that as a transmural infarct. We can see some ST segment elevation, and if it's an old MI, we may actually even see pathological Q waves. So there are different ECG presentations, and you need to understand what each of them means. So remember that once you place a lead over this area, if this tissue here has died, it means that it's going to be recording the electrical activity from the opposite wall. That's what you must actually understand. So you may see some pathological Q waves. So in areas of necrosis, you may see pathological Q waves. In areas of injury, you see ST segment elevation. In areas of ischemia, there may even be some T wave inversion. So remember, in the areas of injury, there's going to be some sort of ST segment elevation. It happens through various phases. So the first and earliest sign that we often see is you get these giant symmetrical T waves. Sometimes even the J point may straighten out. Then eventually you're going to get some ST segment elevation. I did explain a lot of this in my ECG series. Then when there is ischemia that is now about to set in, blood supply has been cut off, you may get this invasion of the T waves, and then sometimes the T wave invasion can actually even persist for weeks, even up to months. So we call this as an MI, which has an age that is indeterminate. Then afterwards, eventually it will become straight, and the only feature that you may sometimes see on an old MI is the pathological Q waves. So in area of necrosis here, it's electrically silent. Like I said, it's going to be recording the activity on the opposite wall of this myocardium. So you're going to see these pathological Q waves. That's what we often see on the ECG. Now, to help you remind about the 12-lead ECG, remember we have our lead 1, 2, 3, AVR, AVL, AVF, V1 to V6. You have lateral leads, which are predominantly lead 1, AVL, V5, and V6. So if you have a lateral MI, you expect to see changes in those particular leads. Then if it's inferior, lead 2, 3, and AVF. If it's anterior or septal, lead V1, V2, V3, and V4. So you need to absorb this, and you need to know which blood vessels actually are supplied by which particular area, because when you're going now for the reperfusion, you know where to target, and you probably have an idea where the thrombi is or where the blood vessel is blocked. Then I already told you, in terms of the ST segment elevation, there is complete blockage. There is this transmural ischemia that is happening. So the heart is going to, or the changes are going to cycle through the following things. You're going to have an hyperacute phase, eventually an acute phase. It would be an evolving MI, then it would be a fully evolved MI, then it would have healed. So the ECG pattern will give you a lot of information on how old this infarct actually is. Remember that the time related changes actually are not going to correlate with what your patient is telling you sometimes. For example, they'll tell you, the pain began recently, but then you see that there are old changes on the ECG. So sometimes the symptoms can actually stutter for hours, because the vessel is opening and closing, it's undergoing spasms before the infarction actually happens. So in the hyperacute phase, the only thing that you may see is these giant, tall, symmetrical T waves. Remember that the amplitude of a T wave is about 5 small boxes tall if you're looking at the limb leads, and it's about 10 small boxes tall if you're looking at the precordial leads. So after this hyperacute phase, then you have straightening out of the ST segment. Then you may also have elevation of the J point or the joining point or the joint point. So here's an example of a patient that had these hyperacute waves. Hyperacute T waves, as you can see, these very tall T waves that we can see in V2 especially, V3, V4, to some extent even in V5. So this person here had an hyperacute MI. I did show this ECG actually in my ECG series. Then afterwards, you're going to get some sort of ST segment elevation. So you're going to compare it to the baseline of the PR segment. Remember, is it above the PR segment? Is it below the PR segment? So there is some sort of variance that you must be vigilant about. So if it is more than one small box above the baseline in 2 or more contiguous leads, then it's likely going to be an MI. So remember, what do I mean by contiguous leads? I showed you that picture about which leads represent which part of the heart. For example, if you have a lateral MI, you expect to see changes in lead 1, AVL, V5, and V6. If it's inferior MI, you need to see changes in lead 2, lead 3, and AVF. So remember, if you only just get ST segment elevation in one single lead, sometimes it's unlikely for it to be ischemic in origin. So again, this is ST segment elevation. It's way above the baseline, and you also even have some pathological Q wave there. Then when it's evolving, you're going to have your T waves that are now being inverted there. So until this point, there is ischemia that's going on. The heart tissue hasn't completely died, which is why if you get ST segment elevation, act very quickly because time is muscle. So at this point, the heart still hasn't died. Now this one, once you see this, it's a fully evolved MI. So you get what is known as a tombstone appearance. This looks like a tombstone. You get this pathological Q waves, you get this tombstone, inverted T waves. So you have a fully evolved MI. At this point, the heart muscle has already died. So here's one with the tombstone appearance. As you can see here, it's affecting V4, so V2, V3, V4, to some extent even V5, tombstone appearance. Then a healed phase, you're going to get this pathological Q waves that are just going to persist. So as we can see on this particular ECG with some pathological Q waves. Here, this is an MI that has an indeterminate age. As we can see here, we have this T wave inversion that we can see on this particular ECG. Again, in leads V2, V1, V3, and V4. You also have it in AVL. Then remember that you're also going to look out for some reciprocal changes. Remember that if you have changes in the superior leads like lead 1, AVL, and V6, you may sometimes get some ST segment depression in the inferior leads. That's lead 2, lead 3, and lead AVF. So remember, in the presence of ST segment elevation, ST segment depression should be considered as a reciprocal type of change. This is the same thing that I've been talking about. I'm not spending so much time hammering this point home because I've talked about it in my ECG series. So I want you to work out this example and you should be able to tell me the answer. Remember our 7-step interpretation of the ECG. Pause the video right now, work it out and see what you can find. And here comes the answer. So this is, of course, standard ECG, 2 big boxes tall, 1 big box wide. It's standard calibration. Of course, don't forget to check for your ECG details. A quick impression of this, it has these ugly morphologies. But of course, it's a sinus rhythm. There's a P wave, QRS complex, a T wave, P wave, QRS complex, T wave, P wave, QRS complex, T wave. The rate is about 79 actually. So 1,500 divided by about 19 boxes, which are in between here. So it's normal rate. The P waves are present. We are seeing that the P waves are present. The PR interval is constant within 3 to 5 boxes, and it's normal. The QRS complex is broad. You can see there's some broadening of the QRS complex in some of the leads, like lead 1 here, there's some broadening of the QRS complex. When you look at the cardiac axis, lead 1 is facing upwards, lead 3 is facing downwards, lead AVF is facing downwards, but lead 2 is facing upwards. So there's some sort of left axis deviation, but I could assume that is a physiological left axis deviation. There is no presence of left bundle branch block or right bundle branch block, no rabbit ears in V1 or V6 or V5. There is no slurring of the S waves that we can see in either of the leads. The RS wave progression is poor because already we can see that V3 and AVF are pointing downwards, so poor RS wave progression. Then in terms of hypertrophy in the atria, there's nothing. We can see in terms of the P waves in lead 2, even the P waves in V1, there's nothing significant. No P mitrale or P pulmonale. In terms of the ventricles, though, if we see the S wave in V1, it's about 21 boxes, small boxes deep. Then if we look at the R wave in our V5, that's about 20 boxes. We sum them up, it's above 35. That's our Sokolow-Lyon criteria. So there is some sort of left ventricular hypertrophy. Then in terms of ischemia and infarction, we can see that there is ST segment elevation in lead 1, ST segment elevation in AVL, and there is ST segment depression in lead 3. We can also see it in lead V1, we can see it in lead V2, we can see it in lead V3. Then there are some hyperacute waves that we can see in the T waves in V4, V5, even V6. We can also see that there are some pathological Q waves that are beginning to form, especially in lead 1 and even in lead AVL. There is no T wave inversion that I could see on this particular ECG. So this would be someone with a sinus rhythm, they have left ventricular hypertrophy, they have an anterolateral MI, so possibly a superior portion of the lateral wall of the left ventricle, and they have some reciprocal changes in lead 3, AVF plus ST segment depression in V1 to V3. Maybe this could be an anterior ischemic pattern, or maybe it's just an reciprocal change. We may not really know. So I hope this makes a lot of sense. If it doesn't, please watch the ECG video. Now, second last important thing is, how do we manage these people that come in with STEMIs? Remember that immediate reperfusion is paramount. That's the mainstay of the management. All other things that you're going to be doing are just going to be supportive. So you want to do an ECG within 10 minutes once they come. And once you confirm that this is a STEMI, you should start a reperfusion therapy, whether through pharmacological management or whether through other strategies, mechanical reperfusion strategies. So you do not want to delay your treatment because you're waiting for tests, you're waiting for other adjuvant therapies. Start the reperfusion therapy as early as possible. So some general measures that we may do, you want to reassure the patient because they'll have this impending feeling that they're dying. Make the patient as comfortable as possible. Supply them with oxygen by a face mask. You want to target your saturations to be above 93%. Secure an IV line. Give them IV fluids if they do need them, if they are hypotensive or they're in shock. And then give them some aspirin. So we dual anticoagulate our patients. So we start giving them aspirin, 300 milligrams stat. If there is no contraindication to them taking aspirin, this is going to help prevent further platelets forming. It may not really take care of the clots. It may really not take care of the clots that have already formed, but it will prevent further clots from actually forming. We also give them a P2Y12 inhibitor. The reason we can give them both aspirin and clopidogrel, for example, is because these drugs work in different ways. Aspirin is a cyclooxygenase enzyme inhibitor, whilst the other drugs are P2Y12 inhibitors. So we give them clopidogrel as well, 600 milligrams as a stat dose, both 300 and 600 milligrams. If your patient is tachycardic, they are hypertensive, we may give them a beta blocker. If they're not unstable. Remember, we use this with caution in patients with COPDs, in those with acute heart failure, in those with AV conduction problems, those with asthma, even in DM patients. If they're in pain, we do treat them with some morphine sulfate. It has some analgesic effect, especially in ACS, and we give that in small doses, about 2 to 4 milligrams IV every 5 minutes. In terms of the nitrates, we can also give them some nitrates either through an oral spray or sublingual tablets, and if those fail, you can consider an IV infusion. So we give them some nitroglycerin sublingual, about 0.4 milligram. You can give it up to 3 times, and then you should administer it at 5-minute intervals. Do not exceed 3 doses. Then we do anticoagulate some patients with low molecular weight heparin, that's your enoxaparin, especially if you're not planning to take them for angiography. We can actually anticoagulate them. So with low molecular weight, 30 milligrams IV of the enoxaparin, you can give it together with your lytic drug, for example, your alteplase. Then you're going to give 1 milligram per kg twice a day subcutaneously. You should not exceed 100 milligrams per day. Then you may sometimes give them unfractionated heparin, especially for those that you plan to take for immediate or early angiography. In some cases, you may give them a glycoprotein 2B3A inhibitor, especially this is done as an adjuvant for antiplatelets, but we don't routinely give it in most of the cases. In another general measure that you're going to do is put them on a high-dose statin because you want to also stabilize the plaque. Now, in terms of reperfusion, which is the mainstay treatment of the STEMIs, 2 important things. You can either take them, or actually medical therapy or pharmacological therapy, which is through the thrombolytics. This one is actually quite feasible in our case here because not every hospital has a cath lab. So only a few hospitals do have the cath lab. So in cases of most of the other facilities, we can actually procure the thrombolytics and put the patient on thrombolytics, then refer them to a hospital that has a cath lab. Or there could be some mechanical reperfusion in the cath lab. So in terms of the thrombolytics, in our case here, this is the best option because most facilities are not able to do the PCI, the primary percutaneous coronary intervention. So we don't want to wait for the cardiac enzymes. We don't want to wait for the other things to show up. Treat them if they have signs and symptoms of myocardial infarction, ST segment changes on the ECG, treat them. So if the PCI is not going to be available within 120 minutes, you should consider giving them thrombolytics, either outer plays, reta plays, or tenector plays, and then transfer them to a center that can do this. Then remember the thrombolytic agents like streptokinase, even urokinase can actually be used. And these are going to be actually dissolving the clot that has formed so that they're going to promote reperfusion of the infarct. But still, these patients need to be referred to a facility that has a cath lab because they need a much more further definitive treatment. So you're going to be promoting reperfusion in the interim to the areas that are infarcted. And this has actually shown to reduce mortality from MI when it's done within 6 hours of onset of the chest pain. So remember that with streptokinase, you may actually have these allergic reactions. Don't stop the thrombolytic unless if the reaction is quite severe. So what are the steps in which we're going to do or undertake when we're doing this thrombolysis? So we're going to check if they have any contraindication to lysis. We start them on therapy within 10 minutes of confirming that it's a STEMI. We monitor their vitals throughout the process. And then after about 60 to 90 minutes, we assess for the success. How do we know that this has worked? You should have greater than 50% drop in the ST segment in the leads that had the highest ST segment elevation. You should have the chest pain that is resolving. This patient must be hemodynamically and even electrically stable. They must have actually a reperfusion arrhythmia. Then you're going to refer them to a cath lab. Remember that if the patient presents beyond 12 hours or the pain persisted beyond 12 hours, we actually essentially manage them as an NSTEMI. Remember the contraindications to TPA use, those that have a stroke or significant head trauma in the past 3 months, those with arterial punctures in non-compressible sites in the past 7 days, those with acute internal bleeding or acute trauma, if the INR is greater than 1.7, if they have an elevated PTT, if they have a thrombocytopenia less than 100,000 cells, if they have uncontrolled hypertension, the systolic BP greater than 185/110, if their glucose is less than 2.8, if they have prior intracranial hemorrhage or multilobar infarct, generally TPA is not indicated. What's our dose? So there are 2 regimens. Often we're going to give it over 1 hour because you want to reassess them after about 90 minutes. So we give them an accelerated infusion. So generally, we should never exceed 100 milligram that you're going to be giving, whether you're giving it accelerated or in 3 hours. If you're giving it accelerated in 1 hour, you can actually, if they're less than 67 kg, you give them an initial bolus, an IV push of 15 milligrams over 1 to 2 minutes, then 0.75 milligrams per kg infusion over 30 minutes. Don't exceed 50 milligrams. Then you give them 0.5 milligrams per kg IV over 60 minutes. So do not exceed 35 milligrams over 1 hour. Then for those that are above 67 kg, you give them 100 milligrams total dose infused over 1.5 hours. Then that's 15 milligrams as an IV push over 1 to 2 minutes, then 50 milligrams IV infusion over the next 30 minutes, then the remaining 35 milligrams over 60 minutes. If it's a 3-hour infusion, those that are less than 65, 0.075 milligrams per kg as an IV bolus over 1 to 2 minutes, then 0.675 milligrams per kg that you infuse for the rest of the first hour, then 0.25 for the next 2 hours. Then if they are greater than 65 or equal to 65, you give them 100 milligrams total dose over 3 hours. So 6 to 10 milligrams is an IV push in the first 1 to 2 minutes, then 50 to about 54 milligrams infused over the rest of the hour. That's literally about 60 milligrams in the first hour, including the 6 to 10 milligram bolus in the calculation. Then 20 milligram per hour for the next 2 hours. These are the regimens that we often use for acute myocardial infarction. Then if you have failed the lysis, how do you know? If the patient still persists to have chest pain despite you giving the nitrates, if they don't have an ST segment elevation which is resolving, if they are in cardiogenic shock, or they have florid pulmonary edema, if they're electrically unstable, they have this frequent premature ventricular contractions, they have this ventricular tachycardia, they have atrial ventricular blockage, then these are patients that you want to send to the cath lab. As you can see here, one of the coronary arteries which is blocked over here. They're trying to thread it open, and eventually there is some perfusion to that vessel. Then in terms of reperfusion, remember we often do our primary percutaneous coronary intervention. So we are going to dilate the artery with the balloon. Sometimes you may place a stent there, especially for those that present with STEMIs within 12 hours. For those that are presenting with the STEMIs, generally, you may consider angiography plus or minus revascularization within 48 hours. And remember that revascularization sometimes can be done with the coronary artery bypass graft. And generally, if the patient is unstable to be taken for theater for surgery, then you want to do a PCI. If they're unstable, if they're refractory, have this refractory chest pain despite medical treatment, if they have acute severe heart failure, but generally you're going to manage them conservatively. Remember the time chronology in our practice. Ideally, your patients will present with typical chest pain. Then the diagnosis will be made in about 10 minutes. You check if there are any contraindication to thrombolytic therapy. Thrombolytic therapy is now instituted in 10 minutes. Then you assess for the success in about 60 to 90 minutes. How do you assess the symptoms, the ECG changes, the hemodynamics of the patient? Give them some adjuvant treatment like dual antiplatelet therapy, anticoagulation, beta blockers, statins, and even ACE inhibitors. So remember, time is muscle. So there is need for this immediate perfusion in the STEMIs. And remember that there is a delay for the patient to actually call the hospital. There may be a delay for the emergency medical services to actually arrive, the ambulance to arrive. And they may sometimes even present to a center that doesn't do PCI. And then this is even going to further delay them. And remember, if the delay is greater than 120 minutes, generally, you're going to give them some thrombolytic therapy. Otherwise, you're going to do primary percutaneous intervention if it's less than 120 minutes like that. And remember, all this time that the patient is delaying up until they have this reperfusion is going to be adding to the muscle death. And remember that time is muscle. So in our setting, if you present now to a facility where they don't have the PCI, they don't have the thrombolytics, what are we going to do? So we simply just give them the morphine, the oxygen, the nitrates, the aspirin, sometimes even give them the clopidogrel. Then we refer them to a cath lab or an advanced facility. We should offer some form of secondary prevention. So we give them aspirin, 75 milligrams to 150 milligrams once a day. Beta blockers have been shown to have both short-term and long-term benefit in patients with myocardial infarction. Remember, the short-term benefits is they're going to relieve pain, they're going to decrease the risk of malignant arrhythmias. Long-term benefit is they'll improve the myocardial performance, they'll facilitate the healing process. Remember, they slow the heart rate, they slow the contractility, meaning that the heart is requiring less oxygen or less demand. So you can give them metoprolol, 25 to 200 milligrams BD, or atenolol, 50 to 150 milligrams OD. And remember, avoid them in those with severe congestive heart failure, those with AV blockage. Then ACE inhibitors have been shown to reduce mortality and to actually even improve the long-term survival because they're going to prevent remodeling of the left ventricle. And this has been shown to lead to progressive heart failure. They should be prescribed within 24 hours, and their maximum benefit is actually achieved when they are given at a higher dose than they are recommended. So in patients with congestive heart failure, remember ACE inhibitors are given indefinitely. So captopril, you can start off at a smaller dose of 12.5 milligrams orally, then increase to about 75 milligrams. But in our case, enalapril is very common. So 2.5 milligrams orally daily, then you can escalate to 40 milligrams once a day. In terms of statin in the long run, generally, even in the acute phase, the benefits, according to the clinical trials, has been quite unclear, but we still do give it for secondary prevention. So remember that patients often with acute MI, it's like a time bomb. Eventually, they're going to develop complications. And one of the things that we're fearing is them reaching into heart failure. So remember, complications are much more common in non-perfused patients, those with intramural infarct. So the short-term complications could be electrical in nature, so they may have heart blockage, they may have sinus bradycardia. These are very common with inferior MI because they are blocking the right coronary artery, which supplies the AV node and the SA node. Then they may have some bundle branch blocks, the right and left bundle branch following an anterior MI, which is affecting the left anterior descending artery. They may have a ventricular fibrillation and electrical storm or ventricular tachycardia. And in terms of structural abnormalities, they may have this acute mitral regurgitation because the papillary muscles are being affected also by the infarction. They may have papillary muscle rupture. They may have ventricular aneurysms, and remember that the blood is going to be pooling under this dyskinetic, this thin area of the left ventricle, and it may sometimes persist beyond 6 weeks. They have this ST segment elevation, and this infarcted myocardium may sometimes evaginate. It may heal with fibrosis, and it can actually lead to as a source of cardiac emboli because of the stasis of the blood. They may have the rupture of the free wall of the ventricle leading to a hemopericardium. They may have a ventricular septal rupture leading to an acute VSD. They may present with a pansystolic murmur that may lead to them going into cardiogenic shock later on. They may have a left ventricle thrombi, which can lead to a stroke. In terms of inflammation, post-MI, they may have what is known as a peri-infarction pericarditis. It's very similar from the second thing that I'll mention, which is Dressler's syndrome. Dressler's syndrome is going to be this autoimmune type of pericarditis that is seen in patients that are after an acute myocardial infarction. Then in the long run, remember that you have these myocytes that are dying. They are decreasing the contractility of the heart, decreasing the stroke volume, decreasing the heart rate, decreasing the blood pressure. And as a result of this decrease in the blood pressure, in the long run, there's going to be sympathetic stimulation and some sort of neurohormonal response, and even changes that we see in the left ventricle, which ultimately are going to result in heart failure. So it's just simply like a ticking time bomb that is waiting to go off. In terms of management of these complications, if they have a malignant arrhythmia, you may perform cardiac defibrillation, even prophylactic defibrillation, prophylactic lidocaine, and even other antiarrhythmic drugs like Britallium and even procainamide can be used. You may have some conduction disturbances like a sinus bradycardia. You may give them atropine 2 milligrams IV to restore the conduction and even restore the heart rate. If they have AV block, they may need a transcutaneous cardiac pacemaker. Heart failure is treated with your diuretics, your salt restriction, your ACE inhibitors, your vasodilators. Use of digoxin in these patients with heart failure due to myocardial infarction is rather controversial. If they're in cardiogenic shock, do an echo to assess your ventricular function. Give them some IV fluids to maximize the left ventricular filling. Use your pressors, your dobutamine, your dopamine, your inotropes rather. Then you may also perform intra-aortic balloon pumping and also percutaneous transluminal angioplasty. I really hope you enjoyed this very long lecture on the STEMIs. I know it was very long. If you did, consider subscribing to the channel. Hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.